Benefits of planning. Good, accurate planning allows for less frequency of changes to an individual CPT, less time and money being spent on administrative activities that give no benefit to the individual's care, and better services for the individual, as county boards and providers will be working collaboratively on providing quality services that meet the individual's health and welfare needs. So now we're going to start talking into payment. So if the number of hours actually delivered by a provider are within this plus or minus 3% margin, the provider will be paid the projected DBU for each date of service. Providers are required to enter actual service hours for the calendar month within 30 days of the end of the month, and in order for the providers to meet their deadline, county boards must meet their timelines. Actual hours may be entered at whatever frequency the provider chooses, as long as they are all entered within the 30-day time frame. So if you're a provider that bills weekly, you can enter in weekly actuals and get paid. If you're a provider that does bi-weekly, you can enter in bi-weekly actuals and get paid. If you're a provider who enters actuals at the end of the month, then you can get paid at the end of the month and have a one-time actual payment fee out. When providing services in a setting without a stable staffing pattern, or one in which the people living there experience frequent changes, submitting the claims at the end of the month may help providers avoid adjustments. These next few slides, and as we go through some of MSS, we're going to show you what that plus or minus 3% really looks at when it comes to that DBU. So we're going to show you what within it, that 3% looks like, what outside that 3% looks like, above and below. Some providers, if you're a providing agency that can wait till the end of the month to do billing, we recommend that because a lot of your adjustments will happen at the end of the months. When we go through, you'll notice that when we do a below adjustment, you'll see that the DBU doesn't get adjusted until you are done with the month of actuals. When an above the 3% goes, you'll notice that above the 3% doesn't happen until at the end of the month when actuals are done. So any adjustments that are actually being made will be made at the end of the month. So if you can wait till the end of the month to do billing, then you'll avoid all those unnecessary adjustments that you'd have to look at throughout the rest of the month.
So providers, we had probably more comments about this subject matter than any other during the training, so I'm going to attempt to make it as clear as possible, and then hopefully Rick will attempt to sweep up what I didn't make clear. So when we talk about plus or minus 3%, I want to make sure everybody understands how they are going to get paid. I know many of you, if not most of you, cannot wait to the end of the month to bill. So this is all going to be presented as if you cannot wait to the end of the month. So when CPT is authorized for the month and you bill weekly and you're putting your actual hours in weekly, that is not going to affect how you get paid like it does today. So today, there's an average hourly rate that is calculated through CPT based on all of the services that are authorized, and what you get paid today is the number of hours that you bill each week that you put into CPT multiplied times that average hourly rate. Under MRC, if you bill every week, you are going to get paid 1 week's worth of the month's projection, and that projection is 100% of what is authorized in CPT. So we'll go back to the 600 hour a month, 150 hour a week example. So week 1, you put in 175 hours. Under the current system, you would be paid 175 hours times the average hourly rate. In MRC, if you put in 175 hours the first week, you are going to get paid the equivalent of the 150 hours times the average hourly rate. The next week, if you were to put in 125 hours, you would get paid the equivalent of the 150 hours. So throughout the month, you're going to get paid the pro rata portion of 100% of what is projected in CPT until you get to the last week. So when Jessica said that's when the adjustments are made, that's exactly correct. So you're going to get an even payment week 1, 2, and 3. They will be the same regardless of the number of hours that you put in. And then the last week, it will reconcile. This is how the reconciliation works. If you are between 97% and 103% of the number of hours that were authorized in CPT, the fourth week you will receive another payment that is equal to the payments that you received weeks 1, 2, and 3, because that will round out the total 100%. If you are below 97%, then the reconciliation will be how many total hours did you bill during the month times the average hourly rate. Then it will subtract the amount that you have already billed in weeks 1, 2, and 3, and your last payment will be a lesser amount because you were below 97%. So that might look like, for example, you had 100 hours week 1, 100 hours week 2, 100 hours week 3, 100 hours week 4. This is for simplistic example. So you would end up with 400 hours when the original projection was 600. So the reconciliation would be the last payment you would receive would deduct out all of the overpayment that you got the first 3 weeks. If you are over the 103%, then your final payment, if you bill it, again will be the same as the first 3 weeks payments because that gets you to 100%, but you have the opportunity to submit documentation to show why you are over the 103%. Once that is approved, then you can go back in, rebill those claims, and get paid the difference. Rick, help me where I may not have explained fully enough.
Let's just make sure that they understand that they're going to get, in our example, their hours was 600 hours. So they're going to get paid for every hour that they provided over that 600 if they were outside or over the 3%. So in our example, if they provided 625 hours, they were going to get paid for 25 hours. The difference between 600 and 625. Not the difference between 25 and 18. That's a key point, and this is something that I'm sure people are going to get mixed up on. But it's, if they are under, it works the same way. If they provided, let's just say they provided 550 hours, they're going to lose 50 hours worth of pay, and that's going to be reconciled in that last payment, just as you explained. But if they're over by 50 hours, they're going to get the full 50 hours paid.
So another way to say it is, if you are below 97%, you will get paid under MRC exactly the same as you got paid under DRA. Correct. It'll be actual hours times the average hourly rate. If you're between 97 and 103%, you will get paid at 100%. So the theory behind MRC is you might be at 101% one month, you might be at 98% the next month, you might be at 102% the next month, you might be at 97% the next month, you might be at 99% the month after that, and that's okay because over time you're going to be within the plus or minus 3%. Over time, we don't have to do all of the changes to CPT every time someone thinks a service level changed, a minute service level changed, because it's a minor change. This is not to say that when there are major changes, not to make them, because you do need to make them, but the little minor changes, we don't need to go into CPT and change all the time. There's a recognition that one month you might get paid a little bit more than what you provided, and the next month you might get paid a little bit less than what you got provided. But over time, it should equal out if you did good planning. The key words are if you did good planning, which is why we are continuing to say throughout this presentation, you must plan together, you must collaborate together, you must communicate often, and anytime something changes in somebody's life, make sure that you look at it through the litmus test of, will it cause me to be over by more than 103%? If not, let it ride.
Okay, Gary, let me ask you a question. If you have a provider that is in the first month at 102.5 on their hours, the second month they're at 102, the next month they're at 103, and the next month they're at 101.5, what would your advice be to the provider?
My advice would be to go in and look at CPT and look at what's not accurate. So the theory behind CPT is for it to more or less even out over time, not just be within plus 3% and minus 3%. So if there's a trend that it is running over 100% every month, then you need to look at what is causing that to occur. Likely what you're going to find is either CPT wasn't authorized correctly to start with. In other words, there was an error, which we're all human beings, folks. We have errors. Or something changed in the person's life and it didn't get communicated. It is up to you to monitor this, not on a monthly basis, but literally on a weekly basis. If you monitor it on a weekly basis, then you will see these things occurring. You will be asking your program personnel on a weekly basis what is going on, which means you'll be able to communicate it timely to the county board, and everybody will be able to adjust on a timely basis.
Okay, I have one other question about this that keeps coming up is let's say that there is a major change during the first week of the month and that somebody is either home a lot more than what you thought they would be. Can you get that change made immediately so that it happens within the month and the provider doesn't have to wait until the month is completely over to have that reconciliation?
Yes. Yes, you can. So what you look for is, those major changes. So did Jessica break her leg because she was out sled riding because she loves the snow? Yes. She's going to be home. First week into the month, that's a major change that needs to be communicated now to the county board. The team should get together and readjust those schedules and get the change in now. It doesn't have to happen at day 60 or day 30 when the provider finally reports something. It can happen then and now. And then it can also happen for the future. So obviously if Jessica broke her leg, it may not be just this month that we're in that she's down and out. It may be the following month as well. So go ahead and make those changes for the following month. We're just asking you to make the changes as prior to when the change occurs as much as possible when it happens. So we don't want it going into week 2 after Jessica's already broke her leg and she's been home for the last 2 weeks, and now we're getting into the final days of the month. You already know you're going to be over your 3%. 2 weeks ago, we should have been making the call. That's what we're looking for in these ones. Now, when Jessica refuses to go to workshop within the first week, one day, because it snowed outside and she wants to go play in the snow, that's not going to cause you probably to be outside plus or minus that 3%. Does that necessitate a call to the county board to say, hey, Jessica refused 1 day of work this week? Probably not. On those circumstances, you can let that kind of go to the end of the month to look at that and go, am I over, am I under, because she refused 1 day. More than likely, you're probably not. You move on with the within plus or minus 3% and you go on to the next month. So we're really looking for those major changes that are going to put you outside that plus or minus 3%. We did build a few reports that'll also help providers with that and county boards with those. So one of the reports that we'll go through, there's 3 that exist for MRC, is that site information report. That site information report shows you the estimated utilization of hours that you have done at this point. So let's say, for example, today is 7:15. You've entered in actuals for up until 7:15. You've got that 150 hours for the whole month. You pull this report up on 7/15, so we've got, 16 more days left of July. And at this time, we have already estimated utilization at 75%. Are you going to make it another 2 weeks being outside that plus or minus 3%? More than likely not. Now would be the time to ask the county board to start looking at a change and then requesting that change, and then why is that change needed. But if you pull the report up and you look and it's 7:15 and you've already utilized 40%, are we going to make it through the next couple weeks because Jessica's refused 1 day of work and we've only utilized 40%? Yes, you probably are. But that's a report that you can use to bounce that utilization back and forth, looking at it going, what have I used to date? What have I got left? We need to make sure we're not making those knee-jerk reactions. So we talk about the below 3%, that above 3%, and what happens within. Within, obviously, you're getting paid at 100%. There's no ifs, ands, or buts to that. You're within that, you're paid out. That actual hours provided above the 3%, we know that if you're going above that 103%, the provider needs to request to the county board with supporting documentation to why they're over to get CPT revised. But that 3% below, we need to make sure we don't make those knee-jerk reactions to take away those hours when we have those crises going on with DSP providers, and making sure that we're providing to the service level and not just what the need is at the time. So don't make that knee-jerk reaction and take that 3% away and say, listen, you're below 3%. We need to adjust your CPT because we're off base. You may not be off base. The good thing is about the 3% is providers, you are getting paid what you actually worked. So there's no harm, no foul there. You will get paid the actuals that you worked based upon the DBU. But what we should be asking is why? Is the change consistent that we need to make the change now because something has happened and the needs of the individual have decreased, but we just didn't project for that? That's something that I think a lot providers, county boards need to get into the habit of too, is asking the whys, finding out why something is occurring. Does it need to be changed? Did we miss something? Is something scheduled off wherever it is? And do we need to move it around?
So providers, I'm going to tell you a couple situations that might cause this to occur and talk about the documentation that you might need to submit to the county board, and then I think Rick will follow up with what is reasonable requests, because we can't give everybody an exact for every situation. So if it's the end of the month and we keep using the 600-hour example, remember this is not week by week by week. So if you're over 1 week and you're under 1 week and you're within the plus or minus 3% for the month, everything's okay. So this is not week by week by week. But one thing that I know happens a lot is someone might go in the hospital, for example. Now, under MRC, you continue to bill for that person. In the past, you did not. Well, the hospital calls you up. Johnny is in the hospital. Johnny has a behavior support plan. Johnny's pulling his IVs out. Johnny is falling out of bed, and Johnny is not being appropriate with the hospital staff. And this hospital doesn't know what to do. So in the past, I know providers would send staff to the hospital, even though you weren't billing for the individual because you couldn't in the past. Well, now you can. That would be a bona fide reason to call up the SSA and say, hey, the hospital is requesting that we have staff there, and these are the reasons why they're requesting that we have staff there. And that becomes a subject of the team to discuss how to deal with that. Do not wait until 2 weeks later at the end of the month to call up the SSA and say, we had staff at the hospital because they asked us to. The minute that the hospital asks to have staff there, you communicate that with the SSA, and through the team process, you determine what's appropriate. Also, at the end of the month, when you realize that you're going to be over by more than 103%, don't call the SSA and say, my reason is because I had more staff hours. That's not a reason. That's just what happened. So if you're going to be over, figure out why you're going to be over and communicate when, Rick?
Now, immediately. SSAs, expect it, expect the calls. Also, when things are changing, make sure that you understand why. As Jessica said, that's going to be the key question. Also, make sure that you already have a plan for what kind of documentation you're going to expect from the providers, and make sure that the documentation is reasonable. You don't want to ask the provider for their firstborn child. It needs to be a reasonable request so that that's something that they can provide and they will have handy when the end of the month comes.